essentially because the state, by its own admission 8 years ago, failed to provide a constitutional level of medical care to its inmates. And after 4 years of remedial effort, proved to be incapable of fixing the problem. In light of what were in fact worsening conditions in prison medical care, the federal court in the Plata case took prison medical care into receivership. The first receiver took immediate successful steps to improve clinical staffing within the system by raising salaries and focusing on recruitment efforts, and began a system-wide assessment of what other changes needed to be undertaken to comply with the state's own regulations regarding prison health care, which are voluminous. I was appointed in January of 2008. By June of 2008, we had secured a court order approving a turnaround plan of action, which sets forth a 4 or 5 year program to fix prison medical care and make significant improvements in the mental health and dental programs as well. We are at about the halfway point in that plan, and we are seeing improvements in care. The overall rate of death has decreased 13% over the last 3 years. The rate of definitely preventable deaths, deaths that would result from clear lack of access to proper care, has decreased by 72% over the last 3 years. And we now have in place an inspection program run by the Office of the Inspector General that measures how well our individual prisons are performing in meeting the state's own policies and procedures for providing care. Good performance measures that we use to evaluate our own progress. I think to permanently reform the system of prison care, we need to finish the elements of the turnaround plan that are underway. Many of those elements at this point are information technology projects to provide very basic infrastructure for operating a cost-effective health care program. Infrastructure like broadband connectivity so we can use telemedicine to provide medical services more cost-effectively. That will result in savings in the costs of transportation and guarding and improve productivity of our own medical staff. We need to have a very basic electronic medical record, which you need for the telemedicine program and to provide basic competent care. And we need electronic healthcare scheduling, which you also need for effective telemedicine and productivity improvements. We do have quite a few one-time projects that we need to complete in the next several years to create a cost-effective system of care that the state can afford to maintain. My other main focus, and it has been essentially top of our mind since February of 2000, when I appointed Elaine Bush, to my right, as my chief deputy, is cost containment. When I was appointed, I took over a system that really was in chaos and which did not have basic systems of managed care in place. We had staffed up, but we did not have in place systems of utilization management, patient care management, a drug formulary, modern telemedicine, effective controls on the rates charged by outside providers and hospitals, a statewide network of outside providers, a central fill pharmacy, or a third-party administrator. As a result, our referrals to outside specialists and hospitals exploded beginning in 2007 and 2008, along with our budget. And we still have waste. We've made progress, as I'll describe, but we still have waste in our programs. Pharmacy, radiology, lab tests and results that are on unacceptable levels. And we are learning every day of areas where we have more work to be done. Over the course of 2008 and 2009, we began putting cost containment programs in place. And we now have an effective drug formulary to make sure that drugs which are prescribed are effective and cost effective. Our compliance with the formulary is now up to 94%. which is an extraordinary achievement in a short time. We brought on a third-party administrator to help us manage invoices and claims in late 2009, and we're reducing our backlog in making payments in a timely manner. Our central fill pharmacy will be opening in the next 30 to 45 days, and we will begin then expanding its operations to all of the institutions. We have expanded telemedicine in the last 3 years by about 75%, so that we now handle 17,000 encounters per year. We can expand telemedicine very substantially once we complete some of the network build-out and start using it for primary care. Our utilization management program was in place by the fall of 2009, and our monthly utilization statistics show that the rate of outside referrals has dropped by around 30 to 35%. Working with the legislature last summer, we established caps on rates charged by outside providers, and we hope to be awarding a contract for a statewide network provider within the next 45 to 60 days. We have filed a report with the legislature in December on these cost containment measures, and an update will be filed, I believe, in April. We are committed to taking the steps necessary to reduce our costs to a level that is sustainable by the state over time, while still meeting the requirements of state law and regulations, court orders, and the Constitution. And I am convinced that we have, in the last couple of months, turned the corner on the increases in prison medical expenses which you have seen in prior years. In particular, my top administrative and budget person tells me that we now are looking at this year a $400 to $500 million reduction in our projected expenditures for the current budget year. As of, say, 4 or 5 months ago, she was anticipating we would be at about 2.1 or 2.2 billion. Now she's anticipating we'll be coming in around 1.7 billion. It is an extraordinary turnaround in our forecast of our expenditures. We do look forward to working with the administration, this committee, and the members of the legislature to make sure that our cost containment measures become a permanent part of providing prison medical care in California. That is why my office is sponsoring a legislative package that was unveiled at a press conference yesterday to put into law utilization management, expanded use of telemedicine, improved pharmacy, and a medical parole program. Turning to the specifics of the budget request this year, I am in support of the governor's request in his budget, both for the increase this year in the BCPs as well as for the reduction for next year. The reduction for next year is without question, a stretch target. But I do believe we are going to be able to make very substantial progress and may be able to hit that target if we all work together towards that goal. I do want to compliment the committee and its consultant on what I consider to be an extremely good report on the budget request. I think, frankly, over the past couple of years, the receivership, and certainly when it started, it asserted control over its budgeting to the extent that not as much information was being shared with the legislature. And this report, I think, brings the subcommittee and ultimately the committee up to date on where we are in the receivership and the goals of our current request. I have reviewed, of course, the legislative analysts' comments as well, and just a very brief reaction to that. The request for sort of holding up positions in order for us to submit much more detailed plans does cause me some concern. We are in the process of moving extraordinarily quickly to change our cost curve, to bend that curve, to hit an extraordinary goal set by the governor. And And I am concerned that if we devote too much of our attention to detailed planning, that my staff will not be able to devote attention to actually getting savings. And I'd much rather be held accountable for the results of our efforts than to be accountable for whether we presented a plan that was to everyone's liking. That the state does have, I think, a tendency to focus on plans in lieu of results. And in my judgment, we should be moving much more towards a system of performance-based budgeting where the focus is on your results and you hold chief executives accountable for hitting those results. As for the IT projects we have, without question, it is judged by normal state standards a large portfolio. But a couple of comments about that. First is, it is a necessary portfolio. It actually is down from 40 projects. We've cut the number of projects in half, and we've really trimmed out ones that we didn't think were absolutely essential to meeting our goal. Second, we actually have, and this is contrary to the usual state practice, I can tell you from having been the state CIO, the usual state practice is to bundle what should be separate projects into smaller numbers of larger projects. We have a tendency, and the reason you do this as a department is the process of getting an approval for a project is so difficult, so time intensive, that you don't want to have 5 projects going forward, even if that's actually the better way of doing it. What you'll do is you'll bundle them into one big project that happens to have 5 pieces to it. It actually is not a good way of managing your projects because you end up with larger projects that have greater risk associated with them. In our case, you could reorganize the 19 projects we have really into just 4 groupings: infrastructure, access to care, pharmacy, and health information technologies. And if we were to do that, we'd have a smaller number, but actually I think the risk would be higher. I am concerned about the, and aware very much, that a lot of our success depends upon our ability to manage these projects. That is why one of the first things I did upon being appointed was to authorize a very substantial investment in project management within the receivership. And without question, we have the largest and most mature project management staffing of any department in state government, which is why our projects are moving forward, largely without incident. I don't know if I'll be able to get all 19 in under budget and hopefully earlier than scheduled, but so far we're not looking, and I don't have any red flags for catastrophic failures of the sort that the state, I think, and the legislature would be concerned about. So I think with those comments, I'd be happy to answer any questions members may have.
Okay.
Thank you, Senator.
I hate to ask you too many questions. I feel like I'm being sadistic.
Oh, well, I would certainly welcome a simple vote.
Usually I'm a masochist. Your 2 comments about being halfway there and then the stretch on next year's savings, which everyone in this building that you visited with is very excited about, and the planning versus measurements. So I think our interest collectively, and as I read the LAO's reports, not inconsistent with that, is we just want to make sure that we're on schedule, and if we have a stretch, we're collectively pushing each other, I guess is the best way to explain it. So maybe the 2 questions is a general question about measurements as opposed to planning, and then how many people do you think, how many full-time equivalents would you have to move to roughly back of the envelope to do what the LAO is suggesting?
In terms of
doing more planning? Yeah, you said that you'd have to move people away from jobs that you indicated are actually getting us closer to not only get the savings, but having you move on.
The difficulty, Senator, is it involves not just my admin people. If this was just a budget matter, I would just sit on my budget people and say, keep answering all the questions.
Right.
The difficulty is that I'll be taking away not just my budget people, but the actual program people, for example, in telemedicine, who are going to make this happen. And really, in part, this is just a timing problem. On telemedicine, for example, was it just Monday of this week? We reassigned the executive who secured a couple of $100 million in savings from the the Utilization Management Program. We reassigned that executive to telemedicine. And this is an extraordinarily effective leader. And we said we want to see a plan in 45, 60 days with implementation to begin no later than November. Now, if I have to now, in addition to having that person focus on internal planning, getting buy-in, she's going to be moving resources internally within the department. If I have to have her now diverted from getting that done to, in addition, trying to explain a plan that is in the process of being developed, that's the problem I have. We actually are planning, and it sounds chaotic, but it is in fact working. We are planning right in the middle of the budget process. So, and on many of these things, I didn't expect to get an $800 million cut in my budget next year. So we are in the process of trying to adjust to that budget request. I mean, a thing to perhaps remember, in the usual world of state government, we would have been informed sometime in the fall of last year that we were going to be facing that magnitude of a cut. I could have begun planning back in October, November. It'd be a little easier if we weren't naturally on the schedule of the budget process. As it happens, that's just not where we are. This was something we essentially learned about the same time the legislature learned about it. So it's really just, mostly it's a timing problem. My executives have been warning me that the workload that I've placed on them already is stretching them. So I'm really just asking for a little bit of patience and assistance from the legislature in helping us get to this goal.
Okay. I think the biggest thing, and we had this conversation yesterday, is you've done such a good job in terms of measuring success and partnering with the Inspector General. So for us, we just want to make sure that we're not taking one step forward and two steps backwards. And I think you feel the same way, and you have to provide those metrics anyways.
We do, and on really all of these programs, I'm perfectly happy as soon as we get more detail to be sharing that with the legislative staff and members about where we are in the planning cycle. It's just that it's not likely to line up neatly with the ordinary budget process, because we're just in a process of continually planning on how are we going to get those additional savings.
I guess the simplest way to say it is we want you to continue your success. We want to be able to measure it, as do you, and we want to make sure that, like is often the case in state government, we don't in our hurry to save money actually. I want to be careful how I say this, because I don't want to suggest that you shouldn't keep stretching for that $800 million, but we want to make sure that you're on target, and then we don't have to come back in 18 months and you're asking for another $500 million.
Understood.
Okay. Any questions, comments before we go on to the LAO? So Senator Weiland, and welcome.
Thank you. Thank you. I just wanted to follow up a little bit with what Senator Desaulniers said to make sure I'm up to speed. I understand yesterday you released some information on some proposed legislation. We don't have a copy of that yet, so it would be important for us to get that.
We'll have our legislative advocate Joyce Hayhoe will share that with you today.
Okay, great. And is there an existing report? We're talking about working with the Inspector General. Is that going forward?
With the Inspector General, this is something that has been ongoing. They have now completed inspections of 26 of the institutions and have public reports on about 19.
Okay.
And they will conclude by the end of this fiscal year inspections of the remaining institutions. And then next year, they do a second round, and what we're looking for then is improvements in those scores. And we have that information here as well.
Their reports, and they're scoring? Is
Yes.
that what they're doing?
Yes, they are. They both produce it's a detailed survey instrument that has a couple of hundred questions agreed to by the plaintiffs and the defendants in the case. And they go in and conduct essentially a paper review of records against those questions, and then they've got a scoring methodology.
Okay. And I concur wholeheartedly with what Senator Saulnier is saying. It's sort of, well, it's not good governance, but it goes along with what we've been working on in improving governance with trying to have metrics or measure performance. So are you doing that as you go along?
Yes, Senator. In addition to these sort of broad measures like the death reviews and the OIG reports, on each one of our major initiatives, at this point, we're getting monthly reports about how we're doing. So, for example, an easy one is in HR and hiring. We set a target for filling this number of positions in all institutions. I've got a monthly report that shows me all of that. On access to care, I set a target. I want to have 85% of scheduled appointments actually met. Previously, we were 50%, 40% in a lot of institutions. I get a monthly report showing me the percentages, whether it's medical, mental health, dental, a breakdown of the reasons for why appointments are not met. In nursing and in clinical, we're getting reports now on productivity. So, and these are all things that we are certainly prepared to share. Increasingly, we post most of this stuff on our website. But we have an enormous amount of what I consider good management information that we are getting on a monthly basis.
The only, I guess there's just a couple other things I would mention. One is, ideally, you would take the measures which gave rise to your appointment and the agreement and all of that, the measures of health, and compare that with similar measures down the road, because at the end of the day, it's less appointments, although that may be sort of an interior measurement, than actual measurements of health, which are sometimes sort of striking in ways that we don't particularly anticipate. So even though in this country we want to have things in heart disease like stents and bypasses, and in Canada they're almost impossible to get, the actual mortality is almost the same. The real difference is that if you need a bypass here, you feel a lot better, as opposed to there where you may simply get your nitroglycerin and drugs and all that, but you actually live about the same. And so I think that's important in determining, is there really, what have we achieved and how much does it cost to achieve it?
Senator, the only report like that I have been routinely receiving previously are these death reports, which are very detailed analyses. We did commission a study by the RAND Corporation to tell us what clinical measures should we be looking at to determine overall health of the inmate population. Because ultimately what we should be doing is looking not at the process measures that currently we're getting good information on. We should be looking at indicators of health.
Yeah.
And we have started. They gave us a report late last year, I believe it was, and gave us something like 65 indicators we should be looking at. We are starting now to implement that. We need to have some better information systems. That's part of the health information set of projects. But we are, in fact, starting to implement those recommendations by focusing on clinical measures of how well portions of our inmate population are doing, for example, in maintaining appropriate diabetes results. So we are moving in the direction you suggest, because that is a more direct measure of how well we're doing than these sort of indirect measures of resources and process.
Okay, that's fine. I'd be interested in, not now but later, if you could get, even if it's just anecdotal, the $100 million savings the individual that in I think you said in utilization management was able to achieve. I'd just like to later on, not here.
We'll be happy to visit with your office, and I'll bring over my director of utilization management, and we'll be happy to chat with you about that.
And one more thing about RAND. They're not probably cheap, but in my experience, RAND has the ability, and I would even think about turning over not just their consulting, but turning over some of it to them. They have a lot of background and ability to get the kind of data that would really help. They did a very interesting study several years ago where they compared two groups. They had a group that, for health insurance, had a minimal copay. It was like $10 copay. And another group that anytime they wanted medical care, they got it. And they compared the two groups so that the health measures of the two groups were essentially the same. And what they found out was that utilization, even with just a $10 or $15 copay, was much less among that group than among the group where there was no copay. But at the end of this period, the actual measurements of the health were essentially the same. So in terms of cost, I think something we need to be very cognizant of, and I hope you are, is that, and I hope this is what they did with utilization, is that net health may not be any different if utilization is managed so it's not just all comers at any point in time.
And that is what we've done. We've implemented the nationally recognized InterQual system, and we very much, our utilization director, her mantra is more medicine is not necessarily good medicine. We have plenty of examples of that in our system.
Great, thank you.
Thank you. And we'll go to the LAO for the fiscal overview that you've given to us.
Anthony Simbo with the Analyst's Office. We're asking the Sergeant to distribute two handouts that we've prepared for today. The first handout we prepared at the request of your staff provides an overview of spending on adult correctional health care, so not just medical care, also including dental care and mental health care. And then the second handout that we'll go through focuses on the governor's specific budget proposals related to inmate medical care. In that handout, we'll go over what are the specific proposals as well as our recommendations. So the second handout will cover all our comments on most of the issues identified in your agenda. So now I'll turn over to my colleague, Aaron Edwards, who will walk you through each handout.
Aaron Edwards, Legislative Analyst's Office. If you'll turn to the first page of the handout entitled Overview of Adult Correctional Healthcare Spending. This first page provides a brief overview of the major litigation regarding healthcare in the prison system. The first case, which is the largest in terms of the scope of services impacted and the costs driven by that case, would be the Plata case, which relates to the delivery of medical care in the prison system. The Coleman case is related to the delivery of mental health care, and it is the second largest case in terms of the scope of services impacted. And finally, there's the Perez case, which pertains to dental care and is the third largest of the ongoing litigation. If you'll turn to the second page of your handout, we provide a figure which shows the increase in healthcare expenditures over the last 5 years. As you can see, actual spending has increased rather dramatically, particularly in the period from 2005-06 to 2008-09. Costs rose by more than 100% over that period. And mainly this is driven by the aforementioned litigation. If you'll turn to the third page of the handout, I'll speak to some of the specific operational changes that have been made that are driving these costs. And the first and largest factor is the increase in contract medical services. In recent years, these contract costs have more than doubled. Looking at the time period between 2005-06 and 2008-09, in just those 3 years, costs increased from $394 million to $845 million. Another major factor has been the addition of additional health care staff. Between the Department of Corrections and the receiver, we've hired about over 2,000 new positions for nurses, physicians, dentists, and psychiatric staff. In addition, we've also increased employee compensation in order to reduce vacancy rates. And then in addition to that, there's also been significant inflation in the area of healthcare, and we estimate that's about 4.5% nationally between 2005-06 and 2008-09. If you'll turn to the fourth page of your handout, we provide a breakdown of the components of that healthcare expenditures per inmate. As the figure shows, we're spending about $16,000 per inmate per year on health care. To put that in context, we spend about $51,000 per inmate in the correction system. And of that $16,000 that we spend on health care, mainly that's driven by medical costs, which are about 2/3 of that $16,000 figure. If you'll turn to the fifth page of your handout, we provide some data regarding current vacancy rates. For healthcare positions overseen by the receiver, we have seen some significant declines in vacancy rates. Specifically for physicians, the vacancy rate in 2006 was 29%, and at the end of 2009, the vacancy rate was about 13% for those classifications. Similarly, for nurses, in 2006 we had a 28% vacancy rate. Now it's about 13%. And for pharmacy staff, vacancy rates have been cut basically in half, from 30% to 15%. For healthcare positions overseen by the Department of Corrections and Rehabilitation, the vacancy rate for psychologists is currently standing at about 10%. For psychiatrists, that vacancy rate is about 29%. It's worth noting there is significant regional variation in these vacancy rates, particularly for rural, remote prisons. It is very difficult to staff some of these skilled positions, and so we do tend to see in prisons, for example, like Avenal State Prison, Pelican Bay State Prison, we do see much higher vacancy rates, and actually above 30% for these physician classifications. I'd be happy to take any questions you have on this handout before we move on to our second handout.
Just on page 4, in terms of the 16,000 number, is that good, bad, medium compared to other?
It's very high. And it does include actually some of, and these are details, but it does include some expenses that actually are driven by mental health and dental. But it's very high by national standards. And I think several things account for it. The staffing is a big part of it. Contract medical is a big part of it. We have a certain number of one-time IT costs where we are trying to do, in a very compressed time frame, a lot of IT build-out that all of the other states will have done over a period of time. So we're concentrating the IT spend in a compressed period of time. And then finally, we have asked the Department of Finance's audit unit, the OSA unit, to do a very detailed analysis comparing our expenditures against prison healthcare expenditures in New York, Florida, Illinois, Pennsylvania, and Texas. And there should be a report back from them sometime in late April or early May, so that we can all get a better sense of an apples-to-apples type comparison.
When you get that, will we look at it in terms of your other outcomes? So death rates are going down.
Sure.
Costs per inmate's going up, but at some point I assume that bend in the curve and where that starts, going back to you said we're halfway there.
Yes.
You know, where that bend is on your time frame might be helpful. And then lastly, just how much, to the degree it's measurable, this prison health care isn't the only place where health care has gone through the roof, so how much of it is attributable just to the larger pressures on the medical field? Maybe that's for future.
The figure that we provide for inflation in healthcare costs is actually for general healthcare.
Okay.
So.
Ready? Anyone else? Senator Weiland?
Of course, I've always got questions. About how much, and does it vary? If I'm say an internist or a general physician, and I'm at Pelican Bay versus Corona, am I paid more in Pelican Bay, and about how much are they paid? Just the primary care doc. Do you know?
Well,
roughly?
we have, I think, the capacity to do a differential based on location, but I don't believe we are doing that. In part because our experience has been, even with those differentials, Pelican Bay is a difficult place for people to go to. Our solution to that really is twofold. First, we've got an agreement with Secretary Kate to implement a medical classification scheme that is currently underway. It's happening right now at the reception centers, where once we've identified who has what type of medical and mental health condition, we're going to assign, based on that classification, inmates to healthcare hub prisons. And then we're going to have other prisons, the ones like at Pelican Bay and out in rural areas, where we're not going to put, as much as we can, inmates who have serious health care needs. So part of what we're going to do is move the sick inmates.
Solve it that way.
Yep.
Second solution is through telemedicine,
Absolutely.
where we really will be able to, up at Pelican Bay, get access to primary care physicians in other institutions through telemedicine. So I'm pretty confident through those two schemes, those two initiatives, we can mitigate, I think, entirely the problem that it's tough to hire a primary care physician up in Pelican Bay.
Yeah, we had that same issue in Central Valley, as Aaron said. You know, some of those were the same way.
I'm sorry?
We had the same issue
in Avenal and the Central Valley.
Same issue.
Same
Difficult
problem.
to recruit. Even with some pay differentials, we haven't been extremely successful.
The second question you addressed, and Senator Saulnier addressed, which is the cost, it's phenomenally high. So I applaud the fact that you're getting this study compared to other prisons, and I'd like to see it. We'd like to see it when you get it, and that would be an interesting time, actually, at some point to hold another hearing. And what would also be interesting is to compare that with the same population,
Yeah.
just the same population out there, and try to determine what's different in the prison system. Now, maybe in some of those states, you know, one thinks of Texas, that the health care might be really, really low because potentially a lawsuit there in a different federal court might have met, in a different state, might have met a different fate. To be
Those things do happen, given the division of the federal circuits.
yes,
Welcome to
they
California.
do. They do. But I think
The Ninth Circuit.
our mission has to be, I think, to get those health care costs in line with the population itself. I will tell you, someone who's bought, and I know Senator Saulnier has done this in when he was in the private sector, who's bought a lot of health insurance. When you have a population, the first thing to do is take a census. You know, most of it they sell to you based on age and gender, and they have enough data to figure out the cost. I would bet that if you looked at the universe in the prison system and you took those same mostly young men out in the real world, the cost is really low because they tend to be mostly healthy and that sort of thing. So as we go forward, I think the goal ought to be, how do we get that in line, with the understanding that some of it is going to be higher just because you're paying your healthcare people probably more than some are getting outside. But we got to. The bottom line is we got to get those costs below $16,000 a person.
I certainly agree with that. Just a couple of additional observations. The prison population does tend to be sicker than the general population, simply because there's a much higher degree of drug and alcohol abuse. There tends to be then a greater incidence of related diseases. The conditions of confinement, if you're being held for a long period of time, do tend to age you more rapidly. Certainly the overcrowding conditions that currently exist create, I think, quite a bit of both medical and probably even more mental health problems. When you look at the overall, and there are a range of diseases that are simply sort of characteristic of a prison population in prisons around the country. And we have pretty much the same types of problems. When you look overall at the cost profile of the inmate population, at least in terms of outside care, it does look very much like the typical public health cost profile, where that first 95% of your inmates don't cost you all that much, and then suddenly the last 5% really hits you. So in our case, we have something like top 850 inmates in terms of expense for outside care. They cost us $135 million. And it is that last segment of the population where you look at them. They always have multiple complex conditions. Many of them are probably within, say, 3 to 5 years of death. They're not at the point where you're near compassionate release. We don't really use compassionate release in California anyway. I think last year there were only 2 inmates on compassionate release. And they are very expensive to care for. That is one of the reasons that we've been working with Senator Leno on a bill that would identify those who are truly no risk to public safety, people who are, initially you'd start, I think, with somebody who's in a coma. We have a number of people on persistent vegetative states, non-ambulatory. Those people, many of them are already being served in community hospitals. It's just that you got 2 guards on them 24 hours a day, and all of their health care expenses are borne by corrections. We think we need to change that in a way that doesn't create any risk to public safety, but which changes their status, so I don't have to have 2 correctional officers there 24/7, and the federal government, through federal health programs, can start to pick up half of those expenses. And that's basically what we're doing through that sort of legislative proposal. Otherwise, these are very expensive people to care for, and it's exactly like normal public health cost distributions. It's that last slice that costs you a fortune.
That's interesting because I don't know, but I think obviously in the population, it's that older group that, and near the end of life, where
yes,
a lot of money is spent. So I think it is important to compare that to the other population. The only other thing we ought to be aware of in the quantity of healthcare dollars we spend, every one of those dollars is a dollar that isn't spent on vocational education, making sure every one of these inmates can read, doing what we don't do, which is trying to actually get them a job when they leave. Things that, because they are going to leave prison, most of them. And so with finite dollars, it's something that really disturbs me. All those programs mostly don't exist, or the vocational education programs don't exist that were there. And the way we release people, to me, is crazy. You know, it doesn't make sense. So I'm just talking about dollars, because I know there are industries and places where if we set it up right, you could move someone to an actual job when they leave. So anyway, thank you.
Thank you, Senator. One last comment. You had mentioned sort of, Texas, they do things differently there, and there are a lot of reasons for that. We are actually very much following what Texas did. Really all of the initiatives we're describing, the central fill, growth of telemedicine, those are all things that the Texas folks who came out and did a study for us a couple of years ago really advised us this is going to help you. And even the medical parole bill is essentially modeled on what is happening in Texas, where they're able to put on medical parole 150 to 170 inmates a year for at least the last 5 years, and I think it's probably for about the last 10 years. And I'm quite confident that's a big reason they're able to keep their costs low, is they're getting the most expensive guys out of their system, and that definitely helps.
One thing I hope when we come back with the study comparing other states is we look at the cost, but some of the drivers and the cost and the success. So telemedicine, obviously, if you looked at Texas, and you're going to accomplish that. And I guess the other part of that is in the bend of the curve, sort of the benchmarks you expect. So you're spending money on IT that's you're counting in terms of ongoing operations right now, but that's going to capture savings.
Exactly.
Right. So where in the bend of the curve you might do that without creating I don't want to make the LAO too happy here with more planning, but to the degree that we can do what I think all of us want to accomplish is an assurity that we're measuring your success and getting as close to root causes as possible.
And I do think we can get you some decent information about when aspects of these programs are going to be rolling out. When are we rolling out in the utilization management, tightening it up again, which we're going to do this year. But we can provide you, I think, with information that will really give you a sense of when you should start seeing results. And I'd be happy to provide that to the committee.
Is it within your purview? I remember being at San Quentin a few years ago and the then warden saying, why is it any surprise to any of you that we give these inmates, we get them, for those who have mental health and substance use problems, at least was his perception there, and he had been the former warden at Pelican Bay, we get them stabilized when they're in the institution, but then we give them $200, and they have to wait 3 to 4 months to get a residential treatment bed. In my county, they go to Richmond, back into areas of poverty. So when you look at sort of cost avoidance, it's $19,000 a year for a residential treatment bed. And I wonder how much we look at that. So they're not coming back in and drive the recidivism rate. How much does that drive continuing costs, as opposed to getting them? If you could actually save money over time and identify maybe a reinvestment strategy, so you're putting money into best practices around those people who need mental health and substance abuse.
Well,
when they get out.
The mental health is not within my direct jurisdiction, but we work closely with CDCR in the mental health program. We certainly see it just internally within the system, where because of the bed shortage problem that our AB 900 construction program is intended to solve, we see inmates cycling back and forth between crisis conditions. You get them a little better, we have to move them back to another bed. They just cycle through. I don't know the extent to which that is a similar problem with recidivism rates. My guess is it is a very substantial problem. We met just last week with the county mental health directors and got quite an earful about their difficulty in providing care, and the fact that we oftentimes don't do a good job of coordinating the release of an inmate with local mental health and other professionals. And I know that CDCR has stepped up a program to do a better job of that coordination, because I think without it, it really does increase the likelihood that a mental health patient in particular gets released, and if they don't have any connection immediately in the community and are receiving appropriate services, they're coming back in almost immediately.
Well, at least I was told by a community-based organization and by the warden that it's San Quentin, which has the advantage of being in an urban area with lots of services. They had $7 million, I think, 2 years ago just to do connections with 3 of the 9 counties, and then the money went away just when they started getting through it. And then lastly, just anecdotally, one gentleman I met who's a constituent, he said, I've been in and out of here 5 times, and I test dirty because I can't get a residential treatment bed for 5 months. Yeah. In terms of getting a job, he can't get a job because he uses. Now, we can punish him, but it's not going to change his behavior, most likely. Yeah. So
it does go back to what Senator Weiland said about investing in the treatment side, and so that we can, and it's the dollar offset with the medical. So to the degree, and you were talking about the bend, if before the receiver came, well, I'll talk about this receiver came on in 2008, our CFO would say that we would probably be looking at current year being 2.3 to 2.4 billion. So I would say, and that's just on autopilot with really no cost containment. Right. I would say that's what we would have been sitting here, is talking about a 2.3 to 2.4 just for medical, not mental health and dental included. The 16,000 that the LAO put in does include mental health and dental. I believe you have dental. Do you have dental in there too?
Yes.
Yeah. And pharmaceuticals are ours, and 30% of our pharmaceuticals are for mental health in our budget. So in any event, I do think we're starting to see the bend, and as the receiver said, we'll be at 1.7 or so, 1.7 billion in the current year, not 2.3 or 2.4, and that's all because of cost containment.
I think, well, Senator DeSaulnier is giving a concrete example of an individual that's dealing with this, and this is beyond the scope of this right here, but somehow we have to look at the money we spend and get the ones that we can rehabilitate, rehabilitate them, or maybe that's even the wrong word. Arrange things so they don't reoffend and don't end up back there. And when I talk to various people, but if you talk to prison guards, some of those percentages aren't as high as we'd like them to be. But I've heard them say at Pelican Bay, the ones I talked to there, and I think probably this is true, most of the guards I've talked to who've served there say, these are bad people, generally speaking. That's why they're there. But, even if we only get a third, 40%, we need to somehow figure out a way of getting them the services and the jobs and the training and the counseling and everything else. I don't know exactly how we do it with not enough money, but I think we have to look at the health care as just part of the overall pot, because, I may have my teeth may be in better shape than it would otherwise be, but is that a dollar that could also have made it so that I don't end up back in prison?
Understood.
Okay. Well said. We'll go on to the next LAO's report.
Thank you, Mr. Chair. At this time, you should have a handout in front of you that's entitled Governor's 2010-11 Budget Proposal for Inmate Medical Care. In this handout, we're going to provide a brief overview of the Governor's major proposals affecting the receiver in the current and budget years, as well as some issues we think merit legislative consideration and our recommendations. If you'll turn to the first page, we highlight some of the major changes the Governor is proposing in the 2009-10 revised budget. The revised budget for 2009-10 reflects $1.8 billion for the receiver. This is an increase of about $424 million over the enacted 2009-10 budget, resulting from the following adjustments: a $95 million net decreased due to various adjustments, primarily related to employee compensation. $408 million increase in funding for contract medical expenditures, and that does include about $4 million in deficiency related to the riot at the California Institution for Men. Also, there's about $111 million increase for the development and implementation of the 19, mostly related to information technology projects. It's worth noting this is in addition to a $45.6 million base budget for IT expenditures that was approved in the 2007-8 budget. If you'll turn to the second page of your handout, we provide a brief overview of the governor's proposed 2010-11 revisions, the proposed budget for the receiver in 2010-11. The governor's budget proposes roughly $1 billion for the receiver in 2010-11. This is a net reduction of about $788 million from the proposed revised level of current year spending. This results from the following changes. There's an $811 million unallocated reduction, and this is in addition to a $181 million unallocated reduction that was passed as part of the 2009-10 budget. There's also a $199 million decrease to reflect a reduction in projected contract medical expenditures. That is a change from the revised proposed 2009-10 budget. There's also an increase of $132.5 million to continue with the development and implementation of the aforementioned 19 IT projects. And then there's a $33.6 million increase and about 350 additional nursing positions to implement new methods of distributing medication in a more efficient manner, as well as adjusting for additional workload needs. And finally, the budget does include an extension of a previously approved temporary appropriation of $45.8 million for pharmaceuticals. That previous appropriation was for 3 years, and it expires in 2009-10. This would be a one-year extension. If you'll turn to the third page of your handout, we highlight some of the issues that we think merit legislative consideration. First, we would note that there is significant risk involved with assuming the level of savings included in the governor's budget for the unallocated reduction of $811 million. We are specifically concerned that at this time we haven't seen a detailed plan from the administration in terms of how all of those savings would be achieved. And of course, achieving this level of reduction, it's about 50% reduction in the budget, will require some major operational changes. Also, the receiver's IT plan does raise some significant project risks. The number of projects being proposed is in excess of what you would normally see within a state agency. Moreover, it's particularly of concern that a lot of these projects are interdependent on one another, and so to the extent that there are delays in any of those projects, then you might see a cascade of delays and cost overruns in other projects as well. We propose that the receiver, the final concern we would like to highlight is that the receiver has been unable to account for about $45.6 million. They have provided some information on how that money has been spent, but they have not been able to provide how much has been specifically spent on each one of these 19 projects, that some of which have been ongoing for the past several years. And if you'll turn to the fourth page of your handout, we will highlight some of our recommendations regarding to these proposals. First, we would advise the legislature to require the administration to provide a more detailed plan on how they will achieve that $800 million reduction. Specifically, the plan should include, among other things, the specific proposals that they are putting forth, as well as how much savings will be tied to each one of those proposals. At this time, we are withholding our recommendation regarding the additional staffing requests. We think that the $811 million, whatever plan the administration proposes for achieving that $811 million unallocated reduction, may have an impact on the need for these additional nursing positions. And we would also note that some of the population reduction measures being implemented and being proposed by the governor may also impact the need for nursing positions. Finally, we would recommend that the receiver prioritize the most critical IT projects and defer those that aren't seen as the highest priority. In our view, the projects that should receive highest priority would be those that serve as the basic infrastructure upon which other projects will rely. For example, the network and the data center, as well as the clinical data repository. And also the projects which have potential to achieve significant savings, for example, utilization management and telemedicine. However, we do recognize that the receiver may have a different package of projects they think are a higher priority, and so we would advise the legislature to ask them to report back on what those highest priorities are. And that concludes our recommendations. I'd be happy to take any questions you have at this time.
I agree with the LAO on IT. IT is can be just a sinkhole of money, and it's just a challenge with IT. Is the IT contracted out to various vendors, or is it done in-house, or how are you actually doing the IT improvements?
Well, we're doing IT very much, and this is a change from the way it was being done by my predecessor. My predecessor was going to build out in a completely separate area, sort of wholly separate from any state IT, everything. When I came on board, I decided to bring it into more of the mainstream of state IT. So, for example, our network build-out and our data center strategy, we are coordinating with Terry Takai to make sure that it supports her efforts to begin consolidating executive branch IT systems in a way that will drive cost efficiencies not only in our shop, but across the entire executive branch. We do have a special arrangement with the state CIO's office where, and this gets back to my earlier comments about we're off budget cycle, where we're sharing information with her office on all of our projects and their progress, and we're completing the standard documentation. But she's been able to give us some leeway on some of the other state IT processes that would really slow us down quite substantially. Most of our IT work is being done in then the typical way. You buy infrastructure, you put it within state systems, state data center, and in order to do development work, you put a contract out to have a system developer come in and help you do the development. At the end of the development contract, you get typically some training so that your own people can do operations and maintenance in the out years. So it is a very typical model for how state IT is done. We are not broadly outsourcing functions because that, I think, gets you into some even worse problems in terms of your ability to manage in the long haul. Elaine, I don't know if you have any other additional comments on that.
The only thing I would say is, and that's not just in this case, but across the entire state and historically, we need to figure out a better way to do IT, and I'm not even saying that this is not the right way, because it's just the hundreds of millions of dollars that we have spent. You know, we tried, that was under Wilson, we tried just to do that with support payments, child support payments, where we're, you know, it's a mess. We're out of conformance with where we're supposed to be. And sort of generally, if we're going to save money, we need to figure out another model somehow. So anyway.
Well, Senator, on that one, I'm glad you raised child support payments. As it happens, I served as the state CIO from 2002 till about 2008, and it was under my watch that we completed the child support project. And one of the reasons that it was able to be completed essentially on time, under budget, still very expensive. IT is never cheap. But one of the reasons we were able to complete it and bring ourselves into conformity with federal requirements is the legislature gave the Franchise Tax Board, which has had success in doing IT, it gave us, for that one project, some procurement flexibility that doesn't ordinarily exist and hasn't ordinarily existed within state IT. And that's one of the reasons that we were able to do a procurement where we could better split the risk between the state and the vendor who was coming in. Now, I do believe Terry Takai, through her efforts and taking over control of state IT procurement, I think she's continuing that sort of model, which is a model of greater flexibility and a much more sophisticated sharing of risk, so it doesn't all land on the state. And when a project goes bad, the state ends up holding the bag. And I would note, since 2002, we have not had, at least during my tenure, we did not have major project failures of the sort you saw in the 1990s. We are trying to do things a little bit differently. There will still be failures. The receivership had its own early IT failure in implementing a Guardian system for pharmacy. And we had to step back, start over, let's do it better. So there will always be failures, but I do think the state's doing a better job.
Well, I'm glad to hear that, and I did not know that we had managed to do that with child support payments. I'm glad to hear it.
One of the things that helped us was the federal government was basically charging us $200 million a year.
I'm well aware of that.
And that tended to incentivize the Department of Finance and General Services and FTB and the Department of Child Support Services to get it done. I'm not suggesting we should always have penalties like that hanging over us, but it led to flexibility so that the project could manage things and manage risk in a much more sophisticated way.
In a world where we reformed governance and had alternate years where we were not in the bill factory, we could spend the time that we ought to spend to really learn about that and really save some big money. But that's a personal pitch. So
perhaps you have a bill in that regard. And actually, we spent a lot of time on this committee on IT, and Ms. Takai has testified a number of times in her success in her previous position in Michigan. So I think, historically, I think of both local government, state government, and California, just an observation, as we get carried away with the shiny things that get seduced by the technology, and people perhaps sold us more than we needed, which I won't go into how much of this I don't use. But then deployment's always a problem, and was certainly in child welfare, which led to the structural changes in getting it out of the district attorney's purview. So we'll keep learning. Let's see. Now we want to go through, unless Finance wants to comment on any of the comments from the LAO or on the first two items, and then we'll go through this. Although we've covered a lot of these on the first two general oversight, we'll go through each one specifically. Have anything? Okay. All right. We'll start with medical services contracts, and unless I hear differently, I'll ask the receiver to make any comments, and then ask the LAO and Finance if they have any. And all of these are recommended to hold open. So the good news, bad news is we're going to keep nagging you and have you come back.
I don't know that I have any particular comments other than what I've already said. It's clear what the driver was for those. It was increased staffing and increased access to care drove, I will add one further thing, that drove a spike in outside care. One of the ways that the receivership improved the quality of clinical staff was by terminating quite a few doctors during the period that we were expanding new staff. And that did create an atmosphere among clinicians where defensive medicine was the norm. So everybody was getting referred out because the physicians were afraid if there was any bad result, their license and job was at stake. We did, several years ago, essentially complete this process of upgrading the physician staff. It has taken a little while for them to realize that the number of efforts to terminate has dropped dramatically, that's not something that we're really doing anymore. But that was part of what drove sort of a hair trigger for referring people out. We've made a huge amount of progress with the utilization management program to reduce the numbers of those going out. And I'm fairly confident that we simply are going to see continuing improvements there because my director of utilization management tells me we have more room for tightening up who gets referred out, and that it's a very substantial improvement that we still can make.
Okay. Any comments from LAO?
Well, as we noted earlier, the costs have been growing very rapidly in this area, and based on what the Receiver's Office has provided us in terms of the projections for current year costs, we do believe that this request is reasonable.
Thanks. All right, that'll take us to another similar challenge. Issue number 2 is pharmaceuticals and medical supplies, and again, we've covered this to a certain degree. So don't feel like you have to be redundant.
The only thing I would emphasize for the coming year that is going to be happening, which is why, again, I'm pretty confident that where we're going to see further progress in sort of bending that pharmacy cost curve, we will be implementing the central fill pharmacy during the coming year. And that will help us in getting better control of inventory management. And there are real dollars associated with good inventory management on the order of 10 to 20 millions of dollars. If we simply could do a better job of knowing where the drugs are, knowing which ones can be returned to stock, the inventory management is a real issue that we can continue to work on. Central fill should also help us in the way in which we distribute medications. And it should permit us to change the business model, essentially, that we currently use, which is very person PY intensive, where we've got nurses delivering medication to all inmates. Central fill is going to help us change the way we do it so we can reduce the amount of PY time, and instead of using nurses, we can use other personnel who aren't as expensive. So I'm fairly confident we need this increase, but you are going to see improvements in pharmacy.
Okay. And just not in regards to purchasing and making sure you get the best purchase, both price and quality, whether it's generic or non-generic. You shared with me, I think, that that's part of the savings.
That is part of the savings. We did last year enter into a fairly good wholesale contract to get us there. There are other things that we may be able to do in the coming year to secure even better pricing, but that depends on conversations that are sort of still ongoing with the administration.
Okay. I just had a brilliant question. Just came to my ear. What was it again, Brian? How much of the savings are attributable in this field to the central fill pharmacy? Back of the envelope would be. Good question.
We're trying to give us a very good question. That one will have to wait for staff to give you, because it's, as you can tell from my presentation, it's actually part of it is central fill, part of it is how much do I change the way in which medication is distributed. Should I count that to central fill? And we actually have a follow-on change here. If we can get to an electronic medication administration record, an EMR, there are quite substantial further savings. Well, I'm not trying to do that just yet. I want to make sure I get the central fill up before I take that next step.
Okay. There's no other comments?
Contact our staff, Brian. We'll happy to try to answer that one.
Nursing relief, again, we've covered that a little bit.
Which one? Where are we?
Page 12.
Did you want to talk about nursing relief? Okay. Page 15.
If you have anything new to add.
Not really, other than both my registry is a problem for us. Our over-reliance on registry is a problem. And our basic strategy has been try to reduce the reliance on registry by, on a going forward basis here, swapping out registry for full-time state positions. In some areas, for example, in the physician area, we actually were able to enter into contracts with registry to reduce the costs and utilization. It's been more difficult with nursing, but we do believe here we can reduce our reliance on registry, which creates both a budget and a management problem. And I think it's probably, from my perspective, more of a management problem than even a budget problem. But this would help us get to a point where we've got the right number of nurses, having baselined the nursing operation with finance, and then I can start putting a great deal of pressure on my executives to be reducing registry, and my next big target is overtime. And I should say on the overtime problem, there we've just got some challenges where certain functions drive overtime and they simply are not budgeted for. But that's a conversation we have to have in another context.
Okay. Any comments? All right, issue number 4 on page 14, medication management. Again, you've covered this, so
I've already talked about that.
Anything to add, LAO or finance? Then we'll move to health management, health information management. Issue number 5. Yes.
Just one quick question on number 4. My understanding is that LVNs distribute the medications, and the question is why someone else at if we could use someone at a lower, less expensive classification to do that.
That is what we are intending to do.
Okay.
With Central Fill, what we'll be able to send out is blister packs that are pre-labeled with the inmate's name on it. It'll make it a lot easier for us to use a lower classification for distribution.
Thank you.
It is staggering how much 85,000 medication distributions each day. It's amazing.
Yeah, in general, the numbers in corrections continue. Even after 2 years, it continues to stun me every time I look at numbers. The number of appointments a month throughout the system is 500,000. That includes everything. It's not like that's all doctors. But the numbers are just huge. It is a population that is very healthcare intensive.
So is that, when we get to the comparison with other states, do you expect that to be high, or is that, don't know?
That I'm not sure. I'm looking, that's in part why we asked for this sort of an audit, because the only information that you're easily able to get is just basic budget information. And you really need to take a deeper dive into, all right, how much access are you actually producing? That's why we're doing the study.
Okay. Again, let's see, issue 5, page 15, health information management. Anything additional? Or any questions or comments from committee members? No. Let's see, item number 6. It's a section letter redirecting positions. It's on page 17 of the staff report.
This was getting people out of the blanket. and getting them into the right positions. So part of our active transparency. Sort of my fault.
Yeah, we had, Senator, and this was sort of part of the chaos of the very early receivership. Part of the strategy of doing things quickly without necessarily following the usual state process was to put a lot of people in what's called the blanket. It is a term where you get to hire people into an area where they're sort of unclassified, at least as best I can tell. There are reasons why you want to have that flexibility. But I think the receivership early on was doing that just to staff up very quickly without going through the more laborious process of figuring out who belongs in what positions. And one of the things we've been doing in this last year is reducing the people who are in the blanket. And so what you're seeing here is the result of that effort, where we've already got these people. We need to redefine, put them in normal positions, simply as a matter of transparency to the state about what these people are actually doing.
And it'd be interesting, and maybe you can respond to this, going back to the earlier discussion of planning versus outcomes and how we know we're on the right track. Did you front load a lot of those administrative headquarter type positions? And with the idea that as you implement some of these things, you start moving them around, as you said, or just eliminating them. So what's the, when we look at the reorg of the total department, and someone said to me, it used to be light at the top and heavy at the bottom, and now it's heavy at the top, heavy at the bottom. So trying to figure out what the right amount is. And is that evolving as you go through the process?
My impression was that in addition to just the clinical staffing, which was an obvious need, that prior to my arrival, the receivership had bulked up at the top as part of its effort to do the planning and assessments to try to figure out very quickly what do you have to do to fix this. And it has left us with a headquarters staffing size that is too big, and we're working on how we adjust that.
And I guess just sort of underlying all this is the progress you're making. How much of a stretch is it to get to those savings? Be perfectly honest, are we just going to score that? And I don't think that's our intention or the leadership's intention. So how much staff do you need to make sure that we actually recover those costs and still keep you on your mission? Right. If you could help us with that, I think in terms of the LAO's recommendation and our discussion before you come back, if staff could have that kind of discussion. So I'm not trying to be Solomon, but I think what the LAO is getting after is what we should be looking for too, is not to be redundant, but we want to make sure we're making progress and still capturing the savings.
Appreciate that.
Okay. If there's no other comments or questions, let's see. 17, page 17, issue 6, section letter, redirect positions. We just did that. So we're on issue 7, project management office. Somewhat redundant, page 19.
Yes, in answer to the question on prioritization, the answer is I started with 40 and I prioritized down to 19. So I need all 19. I do appreciate the contingency problem that, boy, we need to hit our schedules pretty closely or else we can have some cascading challenges. And it should be noted that some of our projects are being managed by CDCR as part of their technology upgrade, Strategic Offender Management System at BIS, for example. I guess part of the choice you have is I can be here for 2 more years or I can be here for 10 more years. How long do you want me to stick around? My assumption is you would rather I be here for 2 instead of 10. If I have to start stretching these things out sequentially, it's just going to take longer. And you will put us in a position where we'll have invested heavily in a first set of projects, and I'm going to have a great deal of infrastructure sitting there waiting for some application to use it. So I'm going to have inefficiencies just from a budget perspective unless I can get all of these things to hit at the same time. So we do agree about the risk. That is, as I've said before, why we beefed up our project management function to try to make sure that we actually hit all of them.
Okay. Maybe the LAO was better to, the $41 million that we're not sure where it's going to, is that under the blanket? Another blanket?
Well,
how many blankets do you have?
That one is, and I'm going to have to go back and look a little more in detail on that. Some of that is simply expenditures that were incurred prior to my arrival where things were more chaotic. And I frankly don't know if they have clear records of some of those expenditures. They just may not exist. So that's something I'm going to go back to my staff and, what information can we provide? I regret being in that position, but there does come a point when if you don't have the information, you just don't have it.
LAO?
Yeah, on the issue of the $45.6 million, it's like the receiver said, how they've been spending the money over the last couple of years, but also how that money is going to be used in the budget year for the 19 projects. Mm-hmm. That's a key question there.
Fair enough.
Okay.
Fair enough. We owe an answer on that.
We want to know how much and what was the Watergate expression? What did you know and when did you know it?
Oh, yes.
Senator Weiland?
A larger question that the committee may already have addressed. How do we know what is compliance? And the reason I'm saying that is that you mentioned it, or it mentions it with the 19 projects. Okay, here it is in the committee information. 6 overarching goals and 25 more specific objectives for how it will bring inmate health care into constitutional compliance. Mm-hmm. Has that been defined in the
constitutional compliance?
Yeah, and the litigation and settlement and all the rest. Is there an agreement on a definition of that?
Well, the stipulation that the state entered into 8 years ago said compliance with the state's own policies and procedures, plus constitutional standards. But in terms of specifics, it really is our existing policies and procedures that the OIG audits against. In terms of my own sense of where we are and what am I looking at, I'm looking at the details of the death reports and our progress there. I look at the OIG results, and I'm looking at our progress in the objectives of the turnaround plan. Now, some aspects of our program, I think, are being brought to a level where I think they can be turned back over to the state for day-to-day management this year. For example, the Access to Care program, where we're measuring how many appointments are getting met. I'm expecting sometime a little later this year to begin turning that over to CDCR for day-to-day management, and all I'll do is monitor the progress reports we're getting. And in fact, I think we have, is that proposal before the legislature to move that, or should I not? Never mind that. There is conversation still being had.
Process.
And I'm looking at the possibility of individual prisons as the OIG numbers get up, and then I start talking to an individual prison and taking a look at how care is being provided there. I'm considering the possibility of approaching the court to say this prison should be turned back to the state. That I don't need to be involved in day-to-day management there. So I think it's actually, in terms of our progress, I think what you'll start to see, and I think beginning this year, is incremental steps towards winding up the receivership. Because I don't believe that the receivership has to be here to the conclusion of, for example, every one of these 19 projects. I don't, I'm not saying I have to be here for that time frame. I'm really trying to look at the key indicators of how well we're doing in prisons as my measure of success.
Okay, I just, since the stipulation does include the phrase constitutionally required level of care, and that is sort of sounds like it's ill-defined. I just make two unrelated comments, and actually you won't recall this, but when you came several months ago to our caucus, and afterwards we talked a little bit about this, that I understood that the judge looked at death rates, And I think one of the things that was mentioned was deaths due to asthma. And I pointed out, and my guess is no one pointed this out to the judge, that death rates from asthma in the general population, even including those who are treated, have escalated dramatically in the last couple of decades. People don't know why, but people who have health insurance and are treated for asthma are more often admitted to emergency rooms and are dying at rates that they haven't before. So just one little thing to remember is that probably was not a very accurate measure of a constitutional level of care. And the only other thing, and this occurs to me because earlier you mentioned diabetes, which is already an epidemic and it's going to get worse. I hope in your definition of health care, you include diet and exercise. Because the one thing you have that we don't have in the general population to control type 2 diabetes, which we used to call adult onset diabetes, but you can't anymore because you get 12-year-old kids with it, is the food you give them. And that actually, in terms of type 2 diabetes, which is the most prevalent, you can control it. I mean, it's virtually with the food you have access to, you can control it, and it's not just the doctor writing the prescription for the. So that's just sort of a side thing, but it's a big cost driver, and it will be in our society down the road where we can't control it. What they eat. I can't make my mother stop eating sweet foods. So, but in prison you can.
You start talking about your mother, I think you should talk to Dr. Lowenthal about that relationship, not with us. In terms of just managing these projects, in the question about when we want to get rid of you, I think you put it in those words, the worst possible choice would be that we keep spending more money, we don't hold us all collectively accountable, and then you're here 10 years from now. So I think that's one of what I think the LAO is trying to get at is, and given your previous history and your previous position, it's at least expectation that we could be closer to being on the same page about, the timelines, the performance standards, when they're going to be implemented, which again, because of your background, I assume would be somewhat easy to do.
On the IT projects?
Yeah,
yes, happy to have that conversation.
Okay.
We have project management, as Clark was saying, office, and we have a project management office that's the most robust we have in state government. And we have project managers that are highly qualified over each one of these projects. And probably one thing I should point out is a number of these 19 projects are already, some are almost done, like mental health tracking. We're basically at most of the institutions. So there's a number of these. I guess I just don't want to leave you with the impression that if this, gets approved, that we're going to start all 19 on July 1st. There's a number of these that were started 24, even 30 months ago. Well,
that you can, during the discussions before you come back with our staff and LAO and finance, to the degree you can have that with as much specificity that doesn't create a whole new planning process would be very helpful.
Sure.
Absolutely.
Okay. Anyone else? That'll take us to issue 8, which is on page 25, and this is the $911 million you promised. I'm just trying to get
you got my attention with that.
811 million. And I guess just to go to my previous comments, I'm sure that the administration doesn't want to just score this, that trick of the bend in the curve, saving money, and still being actually get real savings.
Well, Senator, I'm becoming increasingly confident that we can hit that target, in part because of what I've already seen happening this year. The legislation that we rolled out yesterday, and the work that's been done on that recently gives me some greater confidence. There are still some things that we're doing that we have not yet disclosed, plans that looks like will come to fruition that will give us some additional savings. We have the finance audit report coming in. And then there is conversations we're having with the administration about a model of care delivery and governance issues that, again, I think give both the administration and the receivership higher confidence that that's not just an imaginary number, that that's a real number. The press conference yesterday, as I recall, I indicated that, and I think I got the numbers right, that we were anticipating as much as 350 to 400 million just from the four things we were talking about yesterday, which is pharmacy, utilization management, telemedicine, and medical parole. So, I'm approaching halfway there, and I've still got a number of things up my sleeve.
So, on medical parole, how much do you think? How many inmates would actually be in that category, do you think? And how much are we going to save?
We are very quickly going through the top 1,500 or so to try to determine what the real number is. And the way the legislation is drafted, the decision about whether someone will be on medical parole will be made either by the Secretary or the Board of Paroles. And they would have to do it only for those people who have no risk to public safety. I'm confident that if this were to be enacted, it would be rolled out conservatively initially. So the first year, it's not like you're suddenly going to have 1,000 people. What we would do initially is take a look at those inmates who are truly non-ambulatory. And the way the legislation is drafted and the program is implemented, if they recover, then they come back into the system. So, and I should say many of these inmates are already in community hospitals because we're not providing acute care within the system. So what you're really doing is changing their legal status while they're in the hospital in order to pull down Medi-Cal funding and federal funding. So we're trying to get a much better sense of, all right, what would be the small first group? I don't have that number yet, but my staff is trying to get a sense of first year conservative implementation, what would it look like? But I will say that one's then contingent a little bit upon, assuming it passes, upon how it gets administered. And for example, we have a compassionate release program that the way it's administered, we had only 2 compassionate release cases last year, where I'm confident.
Not very compassionate.
It's not very compassionate. So that one does depend a little bit on how we respond in terms of administration.
Okay. Elio, you look like you were preparing. No. All right. Any other comments or questions? That's our last item before we go to public comment. Does anyone have any concluding comments? You made it through.
I made it through. It's getting worse and worse now, suddenly at the end. But
actually, I just thought of several hours of more questions.
I appreciate that, Senator.
Nothing else? Okay. Maybe we can ask the LAO to create a little room if there's anyone here. Public comment? So I think you get the gist of the direction, and we'll continue the discussions, particularly on making sure that we're hitting timelines and. Good morning.
Morning. My name is David Warren. I'm appearing on behalf of Taxpayers for Improving Public Safety. And I feel very much like Emile Zola when he wrote his treatise, I Protest. I've listened to the explanations, and there are a number of significant concerns. Number one, on the medical service contracts, I'm very concerned about the number of specialists that will cease to be available because of the termination of outsourcing, recognizing there's a desire to encourage these individuals to be employed by the state rather than outside. The disincentive to being a state employee is great, and access to these specialists will create a major problem. I'd like to give but one example. Currently, inmates are transported from as far away as Susanville to Napa for cancer treatment. Although there is a savings in the medical expense for the physician, the expense generated by having to require 2 correctional officers to spend over a day and a half for the transportation costs quickly offsets any savings that may have been available. In the Central Valley, where there is a significant lack of specialists, transportation costs will be increased greatly by the lack of access to these contract specialists. I think this is a point that is not being sufficiently addressed. As far as pharmaceuticals and medical supplies are concerned, access to them is a significant issue, as well as the number and type of medications available. For psychotropic drugs, especially, certain formularies are better suited for some patients than others. If we have a standardized pharmaceutical available, that particular drug may not be the best suited for the inmate, and the paperwork barrier for the physician to acquire the different drug makes it such a significant obstacle that the physician is more likely to cave into the paperwork load than actually obtaining the medication for the physician. I've seen the change in psychotropic drugs in certain inmates because I'm a chaplain inside the prisons as a volunteer, and I see the consequence of that change. Also, the change in the service access for drugs, I don't think all of you recognize the problems of access for an inmate. If you're the big, strong guy, it's easy to get up to the line. If you're the weak, little meek guy, those big, strong guys intervene and make it very difficult to access Medline over and over again. You're often given the choice of eating or getting your medication. And that is a significant problem that is not being addressed in this proposed change and reduction of hours. As far as medication management is concerned, Senator, you've commented about mental health information management systems. This is one of the few points that I strongly agree with the receiver on. I would like to give you but two examples. For years, in my prior life, I did 187 defense for 30 years. And in those 30 years, there was only one inmate, one person I was absolutely convinced was wrongly accused. And out of a sense of moral conscience, my wife and I have maintained our contact with this person because she has no family to provide the quarterly package and visit her once a month. We routinely inquire about her medical care. The department, correctly under HIPAA, requires a medical disclosure form. That medical disclosure form has been lost 15 times in the last 16 years. And every time I request new medical information, or the inmate requires medical information to be sent to me, they say, please provide a form of the disclosure form. Because even though it's been provided, and I provide my photocopy, it's never good enough. I've got to provide a new one. A more difficult situation recently arose. As a chaplain, I'm often called upon for end-of-life compassion for inmates in our prisons. There's a particular inmate who had complications of HIV, Hep C, and cancer. He had executed a form indicating he did not want any extraordinary measures should he go into arrest. That form was lost, and therefore he was resuscitated several times, even though that was against his wishes, because they couldn't find it in the file. I think that's one of the most horrible experiences anybody should ever have to face. It was difficult for me because I kept trying to tell the physicians this is what he wanted, but because of HIPAA, they wouldn't go along because I didn't have a signed consent for disclosure of medical information. As far as access in the prisons, I would like to strongly indicate 2 points. Number one, Senator Ryland, you're absolutely correct. Food is the cheapest way to improve medical care, the reduction of medical care in our prisons. I hope you take the time to go to 2 or 3 and see how badly the food is distributed, prepared, and the type of food which increases medical costs. Any long-term inmate is going to suffer from cardiac disease and renal disease because of the nature and quality, emphasize quality of the food. Too much salt, too much fat, not enough quality items. But the other point I would like to make is medical care in a prison is very difficult to access because there are inmates who abuse the system. It's part of, we have a sociopathic population, that's who's there. And if you don't want the program, I'm sick, which means the sick individual can't get to the medical care they need. There is inadequate triage. the lowest level, the access level in each and every prison. We could save a fortune if we had adequate diagnosticians, either RNs or RN practitioners, to determine who has gastric distress and who has a fractured aorta. We don't have that. And as a consequence, when you sit outside in a large group of people, some with infectious diseases, some not, all caged in a small space, we are exacerbating the spread of contagious disease inside our prisons. We can't segregate anybody. And I guess I would just like to close with one example. At my last visit at Folsom, as a volunteer Jewish chaplain, I was exiting past the clinic, and there was an inmate who I've known for many years who had been transferred to the segregated housing unit, where I'm not allowed to visit. There are reasons, and whether I agree with them or not, those are the rules. He was about to be transported for a cardiac condition. If he had had access to triage, he would not have been transported because he didn't get his medication. And that's the insanity of the system. We're spending a great deal of money because the basic infrastructure, the bottom line infrastructure, simply isn't there. Thank you very much.
David, anyone else for public comment? Seeing no one, thank you, Senator Weiland, for joining us, and thank you, Senator Grady McLeod, for sticking till the end, as always. And thank you. We'll look forward to you coming back.
Thank you.
Thanks. Hope you feel better.